Hi, everyone. I'm Kevin Kunzman, managing editor of HCP Live, and here for another house call video conference interview. Our guest today is Dr. Filip Janku. Dr. Janku is the associate professor in the Department of Investigational Cancer Therapeutics and the Center Medical Director for Clinical and Translational Research Center at MD Anderson Cancer Center. Dr. Janku, how are you doing today?
I'm good. How are you? Thanks for having me as a part of your program.
Yeah, I'm doing great. I really appreciate you taking some time to discuss some growing topics and trends in your field today. And one, that really stands out is the potential of methylnaltrexone as indicated for opioid-induced constipation. And we actually have a cohort analysis that we wanted to talk over with you today and see what we can disseminate from it and what its implication is for real-world practice and just what we should make of this new finding.
Fantastic.
Yeah, great. So I'll just share this with you. There we go. All good there, right?
Yeah.
Yeah, okay, great. So yeah, what we're talking about again is subcutaneous methylnaltrexone for opioid-induced constipation in advanced illness patients with or without active cancer. As a cohort analysis, Doc, if you could maybe start off by telling us a little bit about what sort of research has preceded this assessment and what exactly were we looking to accomplish here?
So methylnaltrexone is actually the interesting compound. It's a peripheral antagonist of the opioid receptors. And it has been researched actually in the first decade of this century as a way how to fight the opioid-induced constipation in patients who actually require opioids for the pain control, which usually is a question of patients with advanced illnesses or advanced terminal illnesses, many of them having cancer, of course. It's a side effect which actually can be quite bothersome and can be significantly impacting quality of life because the constipation can be really resilient and hard to control. And it can even get to the point that some patients actually can compromise the dosing of the pain medicines in order to prevent constipation, which in return actually negatively impacts their quality of life as their pain control is not adequate. So methylnaltrexone actually has been approved a little bit over 10 years ago for treatment of opioid-induced constipation based on some of the studies, including studies which were actually included in the analysis, which is in this recent issue of Pain Management Journal. And it has been used for about a decade in this indication. Methylnaltrexone actually started to receive more and more attention from other reasons because, obviously it's a very effective drug to fight the opioid-induced constipation, but there have been also data coming up from laboratory research as well as from some clinical research suggesting that opioid peripheral receptors or opioid receptors might be also actually implicated in cancer progression. And that was supported by some preclinical data, which were actually done mostly by investigators at the University of Chicago, but also by others. And also actually by the post-hoc analysis of the randomized methylnaltrexone studies, which also actually suggested that patients methylnaltrexone compared to those on placebo not only had better quality of life because of better controlled constipation, but they also potentially lived longer. Obviously, these studies were not designed to address survival or the outcomes, but that was an observation which obviously created quite a lot of enthusiasm. So that's another possible avenue for the development of methylnaltrexone. Interestingly, the survival difference, which I'm just referring to, which was seen with the methylnaltrexone, was actually exclusive to cancer patients, and it was not seen with other advanced illnesses, whatever other terminal illness it was. So that's just kind of like to give you a little bit of background. As far as this paper, which was published just recently, is concerned, I think that tries to address in a post-hoc analysis, it's a retrospective analysis. It was not pre-planned. The study was not designed to specifically address that question. But that being said, it's still quite robust data set. I mean, this study actually focuses on addressing slightly different question. It's a pooled analysis of two randomized pivotal studies, which also are actually important for methylnaltrexone registration. And in this pooled analysis of combined 287 patients, the authors were actually trying to address following question. I mean, and actually the question was, is the effect from methylnaltrexone as far as controlling constipation, but also as far as the side effects are concerned and other potential parameters, is it actually different between cancer patients and patients with other advanced terminal illnesses? And I think the message from this study has been relatively unequivocal and reassuring, suggesting that actually really the methylnaltrexone benefit is not compromised in cancer patients compared to non-cancer patients. That has been reassuring because cancer patients obviously are more complex than patients with some other advanced illnesses. They have actually higher potential for complication and potentially less potential for efficacy, as they might have constipation from reasons other than just being on opioids. But that being said, actually the study did not really notice any significant difference. So I might comment on the studies which were taken into account. So the studies, it was an analysis of two randomized phase 3 studies, which both were actually published a little bit about a decade ago. And one was testing 2 doses of methylnaltrexone versus placebo, and the other one was actually testing 1 dose of methylnaltrexone versus placebo. There was a little bit of difference in dosing as well. I believe one was actually using the single dose, while the other one was actually using the prolonged dosing for multiple day period. And also both studies actually allowed for patients to go to open label extension when they could have used methylnaltrexone in the open label fashion if they elected to do so once they completed the study period. So as far as the sample size is concerned, I mean, I didn't really, and differences between groups, I haven't really found much differences between groups, except for the patients with cancer actually appeared to be using somewhat higher, somewhat actually higher doses of opioids, as far as I can actually see, at least. And that's I believe that's not surprising. I mean, the pain from cancer obviously is far more resilient than probably pain from some other causes. But other than that, these groups actually appear to be comparable. They had actually similar pain scores, and the cancer patients seem to have also higher kind of a level of distress from constipation, which again is probably because of the higher dose of opioids they were on. But what was actually found and what was unequivocal was that looking at the endpoints of the analysis, which was laxation within 4 hours and 24 hours, I mean, the results were actually quite comparable in both cancer and non-cancer patients. I think we can probably look at the page 77 of the article, which is the figure 2. Yeah, that's the one at the top of the. So if we actually look at this one and we look at the dark blue bar in both figures, at the 4-hour figure and 24-hour figure, that actually represents patients who receive placebo, and the kind of a lighter blue shades represent either methylnaltrexone lower dose or the any dose of methylnaltrexone, which doesn't seem to matter that much. But I mean, we can actually look at it for both cancer and non-cancer patients. After 4 hours, there is actually a significant increase of laxation the percentage of response actually means, responders means the number of patients or percentage of patients who did have bowel movement. And we can actually see that in the placebo group, only between 15 to 12% of patients actually had bowel movement, while it was consistently over 50% in both cancer and non-cancer patients. I don't essentially see any significant difference between the way these two groups behaved. If you look at 24 hours, we see actually a very similar picture. Again, there were actually more than twice as many patients with laxation in both cancer and non-cancer patients compared to placebo, on methylnaltrexone compared to placebo. We can actually move one figure below, which is a figure 3, which I also actually think, which is kind of a very telling and might help to get the message of this paper very quickly. So the lines, the dashed lines, are not very easy to distinguish from each other, but essentially the dashed lines are methylnaltrexone patients, either as cancer and non-cancer, and the full lines are placebo patients. And you can actually see this, what this essentially indicates is a probability of having a bowel movement without any additional rescue medications. And what you can actually see is that the curves are overlapping. So that actually means that the cancer patients and non-cancer patients were actually behaving strikingly similar way. And the same is true after 24 hours. So we can potentially move down to another figure, which is a figure 4, which is on the next page. These are some kind of I would say, what I have been just talking about was really the main message of the paper. These are some supporting analysis, which I think are also worthwhile of being mentioned, because these are actually indications about a change in the so-called distress score, which was essentially measured how much patients were bothered or even distressed by the symptoms such as constipation. And we can actually see that the improvement again was consistent between cancer and non-cancer patients in very similar levels. If you look at the pain score, which is actually indicated on figure 5, that's another significant point, because another concern is, I mean, we certainly would like to address constipation, but not at the cost of hampering the comfort as far as the pain levels are concerned. And if you look at actually the figure 5, again, we don't really see much of that happening. And in both cancer and non-cancer patients, there were not actually any notable problems noted in that regard. So when it actually comes to worst pain scores, these figures are again very similar for methylnaltrexone treated groups. So I think we can potentially move down to table 2, which is right before discussion. Yeah, excellent. So because another question is, are cancer patients more prone to adverse effects than non-cancer patients? And again, it's another very relevant question, and there is some limitation of this analysis, because as you can see, this one actually reports on treatment emergent adverse events. What it actually means, that actually means that these adverse events are not necessarily related to study medication, which in this case is methylnaltrexone or placebo, but it simply just reflects adverse events which occurred during the treatment, irrespective of causality. So that's actually one thing which we need to keep in mind, because if we actually look at the table, we can actually see that the cancer overall, if you look at the patients with at least one treatment emergent adverse event, which is the first line of the table, we can actually see that the cancer patients overall actually seem to have more. There was no official statistics provided, so I don't know if the results are statistically significant, but I mean, we can see numerically that there are actually more adverse events in both placebo as well as methylnaltrexone in cancer patients, which I just assume it actually reflects it reflects the propensity of cancer patients to more problems, which again, I guess it's not really surprising to anyone. Another thing which I think we can read out of it, I mean, we can actually read from it, is that there is more adverse events when you use methylnaltrexone, and that would be applicable to both groups, to both cancer and non-cancer patients. And again, it's not surprising. I mean, if you use medication, I mean, inherently some adverse events will happen compared to using placebo. So I think that would be probably the main message from this one. I mean, I think the cancer patients do have more treatment emergent adverse events, and both non-cancer and cancer patients have more adverse events on methylnaltrexone compared to placebo. That being said, I don't necessarily think that we can say from this table that methylnaltrexone would be more prone to side effects in cancer patients. I think that would be probably hard to draw such a conclusion from this table. So I think we can summarize. I think really the message of this article is that the methylnaltrexone and its effect is actually not really any different as far as the primary use is concerned, which is the controlling the opioid-induced constipation, is actually equally effective in cancer and non-cancer patients. And even though the cancer patients appear to have more side effects, there is not necessarily any significant propensity to more severe side effects caused by methylnaltrexone in cancer patients. I mean, I think, again, the higher frequency of side effects is probably more or less caused by the underlying condition. The methylnaltrexone was also associated with improvement in some other parameters, such as patient distress and comfort, pain scores overall, and also did not seem to actually lead to any significant withdrawal symptoms, and that was again these results were consistent for both cancer and non-cancer patients. I think these are really kind of a take-home messages. I think the analysis from that standpoint was interesting. I mean, we have to keep in mind it's a post-hoc analysis, so it's a these studies were not designed to answer that question. I mean, but I think that definitely gives us some confidence in the way we actually look at the use of methylnaltrexone. And I think what is actually the biggest question for me for the future is really what methylnaltrexone does to survival. Because as I just said in my introduction to this whole topic is, I mean, the analysis of 2 randomized trials, which one of them was identical as used in this analysis, which was published in 2016 in Annals Oncology, actually showed that methylnaltrexone patients compared to placebo lived longer. And this effect was exclusive to cancer patients and did not apply to non-cancer patients. And that's actually something which potentially might be additional incentive to study methylnaltrexone as a not only effective way to control patient symptoms and improve patients' quality of life, but also perhaps actually modify the cancer itself.
Wow, that's excellent, Doc, and thank you so much for running through that with us. And from a broader perspective, when I look at this and interpreting it in such a high-risk patient population, working with a drug where there is established and understood treatment of emergent adverse events, culpability. What exactly does this do for, prescribing confidence in the moment where, again, we're dealing with a higher risk patient population here?
I think it's again, it's a postdoc analysis, so the study was not designed to answer that question, none of them, but again, it's a pooled analysis of 2 randomized studies, so it has a certain power. The p-values, whenever provided, were actually quite strong. So I think it's another piece of information which should give prescribers confidence to use methylnaltrexone, believing that this medicine is actually as effective in cancer patients as it is in non-cancer patients, and probably not. The side effect analysis is a little bit more problematic. There were not official statistical comparisons, but at least we don't see any red flags from the adverse event standpoint. I would be a little bit less firm on the conclusion because it hasn't been done as stringently as the analysis of the endpoints such as laxation.
And it being, rapid onset benefit as observed and not really differentiating too much, as you said, between the dosages, it seems like that adds, again, from a post hoc, it does add a layer of confidence to see that sort of a consistency, right?
Yeah, that's also a good point, that it sounds like the dosage actually doesn't seem to matter much, which I think is important. And also you have to keep in mind that there were different schedules even, so that doesn't seem to, at least based on this data, the schedule was not necessarily included as a parameter for the analysis. I don't think we can answer that, but again, it looks like that maybe what really matters is to give this first dose, because actually half of the patients have outcome within 4 hours, and it looks like nearly 2/3 or close to 2/3 of patients actually have an outcome within 24 hours.
Right. And you mentioned a few ideas that you had while going through it in terms of developing a follow-up, or just what else needs to be answered, what kind of voids are still filled there. If you were to develop an assessment of the drug in a similar patient population to sort of follow up and answer those questions that you were posing, what would that look like?
So I think it would be hard to perform another randomized study which would just kind of dig into these type of questions, because I think that even though I kept saying it's a postdoc analysis, it's not designed to answer that question, but I think on the other hand, it's a relatively robust data set, and from the utility of this data and from the prescribing practices, I actually think it gives probably enough data to really, which doesn't necessarily require any additional confirmation. I think the next step really should be to look into the survival, because I think that's, I don't know that we exactly have a data how many actually cancer patients are on opioids, but it's a substantial proportion of patients, especially with advanced cancers. And if actually blocking the peripheral opioid receptors might potentially give them another weapon to fight the cancer, that actually would be really important. And as I said, there is a postdoc analysis which we published in Analyses Oncology in 2016. One of the studies which is actually included in that analysis. The second one wasn't, because we didn't have the data available. But it was a data set of 229 patients, so kind of a similar robust population, which was strictly analyzing the cancer patients versus non-cancer patients, and came up with a very interesting data as far as the survival is concerned. Again, it was a postdoc analysis. There were limitations. A lot of patients were censored because the study design, the study period was actually relatively short, so it had its own deficiency, but we actually found out that methylnaltrexone compared to placebo prolonged survival from 56 days to 76 days in cancer patients. And these were essentially hospice patients. And if you look at actually the patients who had laxation, who responded to methylnaltrexone as the endpoints of the study, then actually the prolongation of survival was even up to 118 days compared to 55 days. So this data were obviously incredibly intriguing. So what is now happening is that now actually the studies are being designed or even slowly implemented, which actually test peripheral antagonists of the opioid receptors as a way to actually treat cancer.
Okay. All right. Great, Doc. And if there's nothing else to really add, I mean, thank you so much. This has been such a great comprehensive discussion on, post hoc analyses, and I'm excited to see sort of how, our understanding of it becomes even more confident and more comprehensive to all these topics you've brought to our attention. I really appreciate your time.
Thank you so much. I appreciate it.